5 minutes after 7 o'clock in Trinidad and Tobago as we move into the second hour of morning edition on this Wednesday morning with all that is going on, politics, COVID-19. It's good to have you with us as we continue to explore the many different issues, SCA coming up on August the 20th and all the different challenges. Well, Trinidad and Tobago's COVID-19 case count continues to climb. 6 new cases were added to the count yesterday, bringing our figures to 154. Well, case 154 is a primary contact of a recently positive COVID-19 patient. And the ministry has raised concerns and is urging the population not to panic, rather, and to continue to follow the guidelines outlined. Trinidad and Tobago has been praised for its handling of the health pandemic, and we are joined now by Tobago-born virologist Dr. Drcindymduke from Las Vegas in Nevada in the United States, joining us at what some would say is the ungodly hour of 6 minutes after 4 o'clock in the morning, although there are many people who actually wake up for prayer at that time. But it's good to have you with us, Doc, once more to take the time to speak with us. Good to have you with us this morning.
Good morning. Thank you so much for having me. And I typically am up by this time usually, so it's okay.
That's very good to hear. So, I mean, I'm sure you're following what is happening in Trinidad and Tobago, and of course you're being kept quite busy by what is going on in the United States itself, with the numbers continuing to spiral upwards there. But what is your sense of what is happening now in Trinidad and Tobago, as we now find within the last 3 weeks local cases being reported in increasing numbers?
I would say it's not surprising to see it. I understand the concern amongst the population. I agree with the Ministry of Health that people should not panic. Now is not the time to stop following precautions. Now is the time, if anything, if you weren't following precautions, to really make sure you're wearing your mask and wearing it appropriately, washing your hands, only going where you need to go, and practicing physical distancing. You know, I think I for sure, I'm moving away from the term social distancing, because it's so murky in terms of its meaning that it's better to say physical distancing, because that's what really matters here, is making sure people understand that, you know, aside from congregating in groups, even when you're amongst people, you need to maintain some distance.
And when you've had a situation as we would have had in Trinidad and Tobago, where for a long time there weren't many cases being reported, of course there's a big question as to the level of testing that is being conducted in Trinidad and Tobago, and whether or not we have really missed a number of cases simply because of the lack of testing compared with our Caribbean neighbors and others in our region. But given what is happening now, is it reasonable to think that maybe people might think that with a level of complacency, that compared to other parts of the world, compared to the United States where you are, for example, that we are nowhere near to the level as being experienced in a much larger country, of course, and that people may say that all of this thing about making masks possibly mandatory, which is not the case at the moment, about this physical distancing and so on, that many will say those things are not really relevant to us here in Trinidad and Tobago.
I agree with you. I think complacency is one of the worst things that can befall anyone when it comes to COVID-19. The complacency is what does lead to spread of infection. I agree that the testing probably could have been more and should have been more, but complacency is what will undo everything. Now, do we think that the country was actually completely rid of the virus, SARS-CoV-2? I think it's erroneous to think that. I don't think that it's gone from the country. I don't think it's just new people coming in who are bringing it in. I think there's a certain level of what we call low-grade transmission in the community, and it's not until you find people who are at risk for symptomatology that you'll actually see symptoms that warrant follow-up. I am very heartened by the level of what I would call contact tracing that I'm seeing, which is once someone does test positive or someone has a strong suspicion for being positive, I am impressed by what the Ministry of Health is doing to track contacts, immediate contacts, and isolate them and get them tested. And, you know, isolation requires 14 days minimum following contact. And so it's really, really important to minimize spread. But as a general population, yes, if you are thinking, oh, this is in the United States, we're certainly doing better than they are, which we are, you are. The truth is, even then, you cannot become complacent. You have to wear your mask. And when it comes to the little ones and our younger ones, I hear talk about SEA, I hear talk about schools reopening. You really have to have a plan in place there, because the younger the child, the less likely they are to truly understand how to practice physical distancing. And so this is not the time to get complacent. It is not the time to reassure ourselves because the numbers are small. Keep in mind, in a population of 1.3 million, only about 6,900 people have been tested, right? And so we haven't even really tested up 1% of the population yet.
And how much of a concern should that be? And many people have been asking that basic question as to how much can you extrapolate from having tested less than 1% of the population?
Yeah. You can look at it in one of two ways. And depending on which of those two ways you look at it, you come up saying it's adequate versus it's inadequate. So in terms of how I was taught epidemiology and sample testing across a broad population, you really want to aim for 10% of your population being tested minimum. Now that of course requires resources, it requires manpower, it requires a laboratory that can handle the number of tests. But if you're looking at it from that viewpoint, then suddenly it's under the number. We're way under where we should be. Now you could look at it another way though, and what people talk about is you do sample testing where you're looking ideally to see that less than 2.5% of those tested are positive. And on that regard, we have done well, meaning of 6,900, I think it was 6,910 tests as of yesterday have been performed. Only 154 tested positive. And so if we believe our testing strategy is adequate in that the test is reliable, so when we have a positive, it's a true positive. When we have a negative, it's a true negative. If we believe that, then it's actually adequate from that standpoint if you apply that metric to it. My worry is whether or not we're sampling enough of all of the population. Some areas might be sampled better than others. And so I think that's where, more information is needed. You can never have too much information when it comes to COVID-19. I'll be very honest. We're still learning about it, but we're also learning that the virus can have a latency phase. We're learning that some people can have the virus the first time, recover well enough, but still perhaps have viral particles circulating. And then if you have a second hit, then they have a second manifestation of the illness or a worsened manifestation. So we can't get complacent as a population and general public. We definitely cannot get complacent as medical providers, healthcare providers, business people. You cannot get complacent at this time.
I know it might be an awkward question, but the issue of masks and whether or not masks should be mandatory has come into the discussion, and indeed the Express this morning editorializing on that, saying that masks should be made mandatory. What's your view on that, Doctor?
Personally, I think masks should be mandatory. From a public health perspective, it's now been proven. And I know there are people who say, well, yeah, because in the beginning, doctors were saying you don't need a mask. Well, I think some of the information that people were propagating about mask wearing initially was actually stemming more from the fact that there was a huge shortage. But we have now seen over and over in large studies that wearing a mask prevents infection. It decreases infection. Nothing will bring it to 0% chance of infection, short of you staying home all by yourself. But it really, really significantly cuts the risk. And if you are in a community where you're starting to see spread, short of a full lockdown again, one of the things that you can take as a meaningful first step to prevent community spread would be implementing a mask mandate. Yes.
And as we're talking about so many different things related to COVID-19, and you mentioned that we should probably stop saying social distancing and use physical distancing instead. Another phrase that has developed within the last month or so is the idea of post-COVID. You hear it now. A lot of things happening in this post-COVID time. And post-COVID means that COVID has gone. But correct me on that. I mean, in the sense that isn't COVID-19 still with us and is likely to be with us for some time yet?
Yes, COVID, it's very premature to say post-COVID. We are at least 18 months away from saying post-COVID. And I say that even though we are hearing more and more promising results of clinical trials for vaccines, we have some vaccines entering phase 3 trial, which is the stage where you actually test to see the effectiveness of the vaccine in a large enough population to know. But we are nowhere near post-COVID, and there's no country that can reliably call themselves post-COVID. And I say that even referencing New Zealand, which is pretty confident at the moment that they have 0 cases of COVID in country. But it's very premature. All you need is one person to really get out there and spread it. And if you have someone who's not practicing physical distancing, who is being maybe wearing their mask so, because again, you can wear a mask but not wear it effectively, and there are people who wear masks but the nose, the nostrils are exposed. That is in no way effective. And it's very quick and easy to spread it. And you can have someone just board a plane, go to Tobago, spread it there, back to Trinidad, and you have an issue. So it's not post-COVID. Anybody who assumes post-COVID is really putting themselves at personal risk, not to mention their community at large.
And nevertheless, I understand the point that you're making, and given your area of specialty is virology, you would have a better understanding of not just how this COVID-19 pandemic is developing, but how are we as far as accelerating development of a vaccine or something that will halt the spread of it. Are you at all encouraged by the continuing bits of information we're getting from the Oxford people, from this group, from that? I know different pharmaceutical companies have been, there's a real race to develop this vaccine. But given the scope of it, you said 18 months, and many people right here in our little team, you could almost sense their eyes opening wide, not thinking that it would be as long as 18 months before we get to a functional vaccine. You remain confident in saying that 18 months?
I am confident, because I think what is lost in the information here is how long the vaccine process takes, but also the time it takes to roll it out and to get it to everyone who needs it, and to get it to enough people who need it, so that you actually have what we call enough immunity in the community, or herd immunity. And so even if a vaccine were developed, the first place where you'd give it would be the people who are at highest risk. So for example, in China, they have gotten to phase 3 of one of their candidate vaccines, and the first people they are giving it to is the military. And so that's what you're going to see. It would be a rollout that goes first for priority for countries, right? And so, in the modern era, given that we're still at varying stages of war or potential for war, military vaccination is the first step in many countries. The next step is going to be your frontline healthcare workers, your frontline first responders, followed up by your high-risk people in your population, those with certain underlying diseases, etc. And then you're going to roll it out to the general population. That takes time. It takes money. It takes manpower. And so even if we were to have a candidate vaccine by January, February, I think it would be premature and very lacking foresight, honestly, to assume that if a effective vaccine is announced in January, that by March everybody would be vaccinated. That's not true. It will be a rollout, and once it's rolled out, then we have to see, is it effective? And even when it's rolled out, you have to see if it's effective. Do we need more boosting? We're still going to be needing to practice physical distancing, wearing of masks, washing of hands. It's not like we're going to be able to say, oh, we've administered the vaccine today, 28 days later, life is good, let's just all start traveling, practicing whatever we want to do and party as usual. That is not what's going to happen, even in the context of an effective vaccine. Not to be long-winded, but yes, I am heartened by a lot of the results we're seeing. We're seeing not just antibody responses, but we're actually finally seeing T-cell responses. And for those who are listening, your immune system actually has two parts to it. It has antibodies, which everybody knows about, which are the things that prevent things from getting into your cells. But when it comes to viruses, antibodies only do so much. You really need think of it as the soldiers of your immune system, the T cells, to be able to identify cells that are infected and get rid of them before they can spread a virus. And that's what some of the more recent numbers and data coming out of the vaccine studies are showing us. So that is very, very promising, but it was all done in small groups of people. We need larger data sets, which is what phase 3 trials will give us.
Which is why we're interrupting you at the early hours of the morning to get your informed perspective. And we really appreciate, Dr. Yu. Thanks very much for taking the time once again to offer us some proper understanding of what we're talking about in the context of COVID-19. Thanks very much once again.
Thank you.
Dr. Cindy Duke, originally from Argyle in Tobago, now based as a virologist in Las Vegas in the United States, where it's 4:21 in the morning.